Triple endoscopy is the most common comprehensive procedure to evaluate a child for stridor of uncertain origin, suspected subglottic stenosis or laryngotracheal malacia, recurrent aspiration pneumonia, chronic cough with no clear etiology, and suspected congenital airway anomalies. These can be evaluated by this triple endoscopy. It allows complete visualization of upper and lower airway and upper digestive tract in single anesthetic setting. It involves three specialists: otolaryngologist, pulmonologist, and gastroenterologist. So, what are the component of triple endoscopy? First component is the direct laryngoscopy with rigid bronchoscopy, that is DLB. It is done by ENT surgeon. Purpose to evaluate the static anatomy of the larynx, subglottis, trachea, and bronchi. You can find subglottic stenosis, vocal cord mobility, airway, malacia or granuloma, or post-intubation injuries. So, for evaluation, you can rule out any these pathologies by this DLB. Second component is flexible fiberoptic bronchoscopy with bronchoalveolar lavage. It is done by ENT or pulmonologist. Purpose of this to rule out dynamic airway pathologies like tracheomalacia, bronchomalacia, and airway collapse. In this case, bronchoalveolar lavage is helps detecting the infection of or aspiration. It can assess real-time airway movement during respiration. Third component of triple endoscopy is esophagogastroduodenoscopy. This EGD is done by the gastroenterologist. Purpose of this to evaluate esophageal, gastric or duodenal causes of GRD. It is for rule out of gastroesophageal reflex, esophagitis, and structural abnormality in the stomach or duodenum. It can also help to take out biopsy from esophagitis or GRD cases. Indications of triple endoscopy are stridor of uncertain origin, suspected subglottic stenosis or laryngotracheal malacia, recurrent aspiration pneumonia, chronic cough with no clear etiology, and fifth is suspected congenital airway anomalies. These are the indication. What are the advantage of triple endoscopy? Advantages are complete airway and digestive tract evaluation in one session, avoid multiple anesthetics, and it detects multi-level pathologies, both airway and reflux disease, and it also facilitates multidisciplinary management. Risk of this are airway trauma or edema, hypoxia during procedure, aspiration or bleeding may be there. So, in summary, triple endoscopy having DLB that define static airway structure, flexible bronchoscopy that define dynamic pathologies, and EGD that define the gastroesophageal factor contributing to airway disease.